All right, hello everyone. My name is Matt Kolevar, and I'm excited to present our work on the development of a patient-specific cartilage graft using MRI and 3D printing. Authors have nothing to disclose, but we would like to acknowledge two sources of funding listed here. So there are many different treatment strategies for the treatment of focal chondral defects, including microfracture, MACI, osteochondral allograft, and off-the-shelf grafts such as Cartiform and de novo. Each has its own benefit, but also major limitations, and the ideal treatment strategy remains unknown. A few years ago, our group published data demonstrating that augmenting microfracture technique by implanting a 3D printed polymer scaffold, which was biofunctionalized with aggrecan in a rabbit model, doubled the thickness of regenerated cartilage tissue, tripled the number of chondrocytes present, and increased the expression of type 2 collagen nearly tenfold compared to microfracture alone. You can see here on the bottom row, thicker cartilage and more chondrocytes compared to the control group on the top row. So in order to take this a step further, we needed to scale up from the small flat graft that we had in the rabbit model. When you start designing a bigger graft, ideally eventually for human knees, the contour really starts to matter because you don't want any articular step off. Ideally, you could have a patient-specific anatomic graft with perfect contour, but to date, an artificial one does not exist. So our specific aim was to test the accuracy of a novel method for 3D printing and implanting individualized anatomically shaped grafts for the treatment of cartilage defects in the human cadaveric model. Our hypothesis was that an individualized anatomic 3D printed scaffold designed from MRI data would provide a more optimal fill for a large cartilage defect compared to a generic flat scaffold. So how do we do this? First, 4 focal cartilage defects were created in paired, fresh, frozen human cadaver knees aged less than 40. Defects were created in both femoral condyles, the lateral facet of the patella, and the trochlea. MRI scans were obtained of each knee to generate DICOM files. These were uploaded to a 3D software program, and the subchondral bone and cartilage were identified and outlined. It might be hard to see the defects on the screen, but the pink outlines the subchondral bone, and we were able to outline the cartilage as well. Final graft design was saved as an STL file ready for printing. The images here show the printable 3D graft mimicking the articular cartilage, from which the region of interest corresponding to the cartilage defect could be selected and printed. All cartilage grafts were 3D printed with polylactic acid on an extrusion-based printer. Shown here are some examples of the anatomic grafts. The anatomic grafts were fixed in the corresponding cartilage defects in the left knee using tissue adhesive. Shown here are some intraoperative photos after implantation demonstrating good contour on gross examination. Corresponding control group grafts were printed with the same dimensions as the chondral defect, but without radius of curvature, and implanted in the paired right knees. Photos here show poor fit and gross examination. Repeat MRIs were obtained for visualization of graft fit. You can see the control group grafts here as the dark lines that decrease signal. Graft step-off was measured as the distance between the surface of the graft and the native articular cartilage surface in a direction perpendicular to the graft, to the joint surface. Graft contour was measured as the gap between the undersurface of the graft and the subchondral bone in a direction perpendicular to the joint surface. Differences in means were compared between anatomic and flat control group grafts. Again, grafts here are seen post-implantation as the dark lines that decrease signal. You can see these step-off measurements in red are noticeably better in the anatomic grafts on the left-hand side, and no protrusion beyond the native joint surface. Yellow arrows indicate contour measurements, which were undetectable in this example MRI slice on the left, and 0.9 millimeters in the corresponding flat graft. In the axial comparison, you can again appreciate a significant difference in step-off and contour between the anatomic and flat trochlear grafts due to the patient-specific nature of the graft on the left. Graft step-off was significantly better for the anatomic grafts in all locations. Measurements are shown here. Graft contour was significantly better for the anatomic grafts in the lateral femoral condyle and the trochlea, and contour was better for the flat graft in the patella. So this study provided a validation of a process designed to fabricate an anatomically accurate cartilage graft using MRI and 3D printing technology. Anatomic grafts demonstrated superior fit compared to generic flat grafts in a human cadaveric model. As you can see on the bottom right here, we started to introduce a predetermined pore size and plan to use different materials for the next iteration of this design. Ultimately, this study lays the foundation for future in vivo studies in a large animal model with further improvements in graft design. Thank you.